Imagine taking 19 pills per day while having to go to hemodialysis 3 times per week for 4 hours and still not feeling well. Some of the pills either are not working or make you feel worse. Our research team plans to deprescribe medications to decrease polypharmacy and improve how patients on dialysis feel. Our study group consists of nephrology experts from across Canada, including experts in the field of statistics, pharmacoeconomics, and clinical tool development. We also have a group of dedicated patient partners who have been with our project since inception and provide valuable insights into designing our project. So here's Mrs. P, an 84-year-old woman who has been on hemodialysis for the last 6 months secondary to her diabetes. She is a widow and living alone. She's had 3 falls in the last year and is experiencing confusion and memory loss, so her kids are worried about her. Here's a list of her medications. 18 medications per day. This is very typical of a patient on dialysis. Due to the many related medications, she's been trapped in a prescribing cascade. This is when a patient has a reaction to a medication and a new medication is started to treat this new reaction. And the patient has a reaction to the new medication and yet another medication is started to treat the new reaction, and so on. How did this happen with Mrs. P? Because Mrs. P has memory issues, her friends told her to take ginkgo. But then she had an increase in blood pressure from her ginkgo, so her family doctor started her on a blood pressure medication called amlodipine. Her friends told her to take aspirin. According to them, it's important to take aspirin if you have high blood pressure. She then develops foot swelling from the amlodipine, so her family doctor starts her on a water pill called furosemide. The family doctor also starts her on a sleeping pill as she's not been sleeping very well. So we can see how the prescribing cascade to lead to so many pills, or what we call polypharmacy. This is the problem. Polypharmacy. Polypharmacy means many drugs. It is also defined as 5 or more drugs. Polypharmacy also means inappropriate choices of medications or doses. There are many consequences of polypharmacy. First, on people, there's decreased adherence, drug-drug interactions, and adverse drug reactions. 68% report adverse event after hospital discharge. 72% of those are due to a medication. On healthcare utilization, there such as hospital admissions that could be preventable that are drug-related. On cost, $4.4 billion spent from public drug programs on drugs are for the elderly. This is 20% of healthcare spending. Patients on hemodialysis take 12 medications per day on average. Up to 70% of these medications may not be appropriate. And patients on hemodialysis are rarely included in clinical trials. So the solution. To address this problem, our research group is working on a set of clinical tools that aim to safely deprescribe certain medications in hemodialysis patients to decrease polypharmacy. First, the goal of deprescribing is to identify and stop medication where harms outweigh potential benefits. Our project targets 9 common medications taken by patients on hemodialysis using a guided toolkit for clinicians and patients. The toolkit consists of, first, an algorithm. It is a stepwise approach with decision-making triggers to help the clinician in deprescribing the medication. This is accompanied by an evidence table. This is how we came up with the deprescribing plan for each medication. And importantly, a monitoring tool for clinicians to easily track the progress of deprescribing attempts. Many patients are often uncomfortable with changes to their medications. We worked with our patient partners and patients across Canada to develop specialized bulletins for each of the medications and videos on each medication and the deprescribing process. These materials help patients understand the medications, risks and benefits, as well as how deprescribing will be done. As our tools underwent a national validation process, what we did is we validated 3 different algorithms with 15 different clinicians across Canada. This is an example of one algorithm divided into sections, and the reviewer scored each section on the content and the layout of the algorithm. Then changes were made to the algorithms based on the feedback and scores, and we did 3 rounds of this to review each of the algorithms. In the end, we had 45 different clinicians across Canada review our algorithms. The demographics of these clinicians are included here. We had nephrologists, 24 of them, 17 pharmacists, and 4 nurse practitioners. We also validated our patient tools, both the bulletin and video. Thank you to our patient partners who made this happen. Along with our research coordinators, they interviewed 72 patients across 3 sites, Vancouver, Winnipeg, and Toronto. We now have a bulletin and video for each of the 9 medications in our Prescribing program. What are our next steps? Implementation of our toolkits in practice. We started in 2016 with selection of the medications to be deprescribed, and then developed the Prescribing toolkit. And between 2018 and 2021, we validated the toolkit, and now we're excited to implement our toolkit in hemodialysis units across Canada. Thank you to Can-SOLVE and our team for all the support in getting us this far.